All right, so diving in today, we're looking at something that I think most people have a pretty strong gut feeling about: justice, inequality, and how those things impact our health. Like when you see these big differences in how long people live, how healthy they are, and it seems connected to wealth or where they come from, it just feels off.
Yeah, definitely. It's like something's not right there.
Exactly.
And in this deep dive, we're going to go deeper than just that gut feeling, right? We'll explore what philosophers have to say about this. What actually makes a difference in health and injustice? Is health different when we talk about fairness, or is it, just the same old ideas about equality just playing out in our bodies?
Right, right. So to break this down, we've been looking at this Stanford Encyclopedia of Philosophy. They have this great entry on, it's called Justice, Inequality, and Health.
Perfect.
So we've done the reading, and we're going to lay out the key arguments for you.
Yeah.
We want to give you a solid understanding of how philosophers think about this, how these health differences, how they connect to these big ideas of justice and equality.
Okay, let's jump right in.
Yeah, let's do it.
First, let's just lay out the facts, right? This isn't just some theoretical discussion. Like the numbers show some serious differences.
Yeah.
For example, in the US, a man, if he's in that top 1% income bracket, can expect to live almost 15 years longer than a man in the bottom 1%.
Wow.
For women, the gap's a bit smaller, but still over 10 years.
It's huge. And it's not just about living longer, right? It's about how well you live, the quality of that life. There was this study I was reading recently. It found that in the U.S., over 38% of people in that bottom third income-wise, they say they're in fair or poor health, compared to just 12% in the highest income group.
Yeah.
And having health insurance helps, but it doesn't erase those differences. It's clear there's more to it than just that.
Absolutely. And these disparities, they're not just about income, right? We see them with race and ethnicity too. In 2019, average life expectancy for Hispanic Americans was about 82 years. For white Americans, non-Hispanic, it was closer to 79. But for Black Americans, non-Hispanic, it was significantly lower, around 75 years.
That's a big difference. And, the COVID-19 pandemic really made these inequalities so much worse, so much more visible. I mean, it's tragic. Between 2018 and 2020, the pandemic hit life expectancy much harder for both Hispanic and Black Americans compared to white Americans.
And if we zoom out, look at the world as a whole, the inequalities get even more drastic. Back in 2016, the average person in a low-income country lived to about 63. But in a high-income country, it was almost 81. That's an 18-year difference.
Wow, that really highlights, how big this issue is. But like philosophers often point out, not every difference we see in health, that's not automatically an injustice. Like on average, women live longer than men. There are reasons for that, biology, maybe some social factors too, but we wouldn't call that a societal injustice, right?
Exactly. And that's the core question here. What's the difference between just a health difference and one that's a true injustice? And to answer that, we've got to look at what's causing these health inequalities in the first place.
And that brings us to these social determinants of health.
Right.
It's not just about healthcare, it's about everything else in society that shapes how healthy we are.
Right. The evidence really shows that these inequalities, they mostly come from things outside healthcare.
Like what kind of things are we talking about?
We're talking about, well, social determinants of health. These are things society can control, things that affect your health.
So not access to doctors and hospitals, but
It's more about your income, your education, the type of job you have, where it stands in society, even experiencing racism and your social class in general. These all matter. They affect your health. It's not that healthcare isn't important, but these bigger social factors, they play a much bigger role.
and to see this in action, we can look at what's called the social gradient in health. It's a pattern that shows up over and over again in many different societies.
Yeah, it's really striking how consistent this is.
So explain this gradient. What's it all about?
Basically, it shows that as you move up the socioeconomic ladder, your health gets better. And it's not just that the poorest are the least healthy, it's that each step up, even small steps, seems to come with better health. It's like a gradual slope all the way to the top.
And the Whitehall studies are like the classic example of this, right?
Yeah.
Those were done in the UK with civil servants.
Exactly. Michael Marmot and his team, they studied these British civil servants. They had all sorts of different jobs, from high-level admin to, more manual labor. What's interesting is these folks, they all had stable jobs, lived in the same area, and had free health care through the NHS. So they were controlling for a lot of factors that could mess up the results.
And even with all that, even with free healthcare and no real poverty,
Yeah.
the higher up you were in the job hierarchy,
Yeah.
the healthier you were. It wasn't just the lowest rung that was unhealthy. It was this consistent pattern across all levels.
Exactly. Figure one from that first study, obviously we can't show it here, but it showed this gradient so clearly. And get this, they statistically adjusted for things like smoking, blood pressure, cholesterol, the usual suspects. And still, when you look at heart disease deaths, in figure two, the gradient was there. So those usual risk factors, they only explain part of it. There's something about your place in society, something more fundamental that affects your health, even when your basic needs are met.
So it's not just about individual choices, right? It's about where you stand in society, and that affects your health. Even when you're not poor and you've got access to health care, that's a powerful finding.
It is, it is. And like we said, this social gradient, it's not just about jobs, it's also about income, education, social class, and particularly in the US, race and ethnicity.
So it makes you think, right, are all these different social factors basically pointing to the same root problem, or are they each working in their own way to affect health?
Yeah, that's a big question. Could be that each factor is a sign of something deeper, something different, like income that might directly affect whether you can afford healthy food or safe place to live. Education, maybe that's about understanding health information or making healthier choices, or maybe all these different factors are just different ways of measuring the same underlying disadvantage. And then there's education. That one might have a more direct effect on health, maybe through cognitive development or giving people more control over their lives.
And it's not always a one-way street either,
That's all right.
right? Sometimes bad health can lead to less income, less education, and a worse job. It can go both ways.
Exactly. Think about someone with a chronic illness. It can be hard to keep a job, to move up in your career. That can lead to lower income. And there's a link between income and mental health, too. Low income can really contribute to mental health problems. And the other way around, mental health challenges can make it harder to get a job, to earn a steady income. It's a cycle.
And then there are the relationships between these social factors, right? Like
Yeah.
how much education you get can affect how much money you make, what kind of jobs you can get. And then the factors like racism, that can affect so many things at once: income, education, job opportunities. It's this whole web of interconnected disadvantage.
Absolutely. And even just focusing on income, there's debate about how we should even measure it. Is it your absolute income, the actual amount you have, or is it relative to everyone else? The relative income hypothesis that suggests that inequality itself, regardless of your actual income, can be stressful and bad for your health. It's still a hot topic, lots of research going on looking at how we compare ourselves to others and how that impacts our health.
So it's clear it's not a simple cause and effect thing. Now, shifting gears a bit, there's a fundamental question about how we think about these inequalities.
Mhm.
Should we focus on differences between groups or on the variation among individuals? A lot of the data we've been talking about that seems to focus on group differences.
Yeah, a lot of the talk about health inequalities has been about comparing average health in different groups, like different income levels or racial groups. But some philosophers and researchers say, hold on, we should be looking at the whole spectrum of health across all individuals, not just group averages.
What's the thinking behind that individual focus?
Well, some, like Murray, Geikidu, and Frank, they say that looking at individual data gives you a more complete picture. You see all the nuances of the inequality. But the philosophical debate goes deeper than that. For example, Daniel Hausman, he argues that differences in health between individuals, those aren't automatically unjust.
Wait, that seems a bit counterintuitive. Why would he say that?
His point is, health is only one part of well-being. People can have different levels of health, but still be equally well off overall. They might have different advantages in other areas, like strong social connections, achievements, or access to different resources. So just because someone's healthier doesn't mean they're better off overall. It's about the big picture, the whole package of well-being.
So, you could have a healthier person and a less healthy person, but the less healthy person might have other things going for them that make them just as well off. I get it.
Right. Now, Hausman does make an exception for what he calls incompensable inequalities. These are health differences so big, so serious, that they probably do mean someone's worse off overall, no matter what else is going on in their life. But for most health differences between individuals, the ones that can be balanced out by other good things, he says we can't just assume they're unjust.
Makes sense. But what about differences between groups? Does he see those differently?
He does. He says that when we see health differences between whole groups, that often tells us something about overall well-being or social standing. So, while differences between individuals might be balanced out by other good things, group differences, especially when they're large and systematic, those often point to broader problems of injustice in society.
And Iris Marion Young, she takes a different approach, right? She really emphasizes these structural inequalities when talking about group differences.
Yes. Young argues that when we're concerned about justice, we should really be looking at inequalities between groups. Her point is, many injustices come from problems in the basic structures of society. These structures shape people's opportunities and their life chances.
So looking at group health differences can help us see these deeper structural problems. Things like laws, policies, or even just how officials act, these things can systematically disadvantage certain groups and harm their well-being.
Exactly. And Paula Braveman and her colleagues, they built on this with their concept of health disparities. They don't see any health difference as a disparity. It has to be linked to social disadvantage. So it's not just about differences, it's about differences that are rooted in injustice. These disparities often come from discrimination, and they can make social inequalities even worse.
So we're talking about structural health inequalities. That's a key concept here.
Absolutely. But not everyone agrees that group-level definitions are the way to go. Philosopher Casper Lippert Rasmussen, he raises some interesting points about this.
What are his concerns?
He's all about individual level definitions. One thing he points out is within any group, you're still going to have variations, inequalities, in health. So if we're worried about justice, why should we only focus on the differences between groups and not the ones within them? It's a valid point.
Yeah, like just because one group has a lower average income doesn't mean everyone in that group has the same health. There can be lots of variation within the group itself.
Right. His second point is about how we even define these groups. There are so many ways to categorize people. Why focus on income, for example? What makes that more important than other groupings when we're talking about health justice? He's worried about being arbitrary in how we choose to divide people up.
And while some might say we should define groups based on the things that cause health inequality, Lippert Rasmussen isn't sure that those groups will always line up with the groups where there are real, morally important health differences. He also makes a point about natural injustice. That's when health inequalities happen because of things outside of society's control. And he says, to see those, we need to look at individual data.
Nir Eyal offers another take. While he's not totally on board with focusing solely on group differences, he does see a moral reason to pay attention to what he calls status group inequalities. These are differences between groups that have different levels of social advantage or disadvantage. He argues that these inequalities, even if not always unfair in every single case, often point to deeper problems like discrimination or lack of solidarity. They can be signs of deeper luck egalitarian injustices because people in disadvantaged groups often face risks and challenges that are out of their control.
And when we're thinking about policies, how we actually try to solve these problems, Yukiko Asada points out that how we define inequality matters a lot. For example, individual data might be better for comparing health between countries, but group definitions might be better for figuring out who to target with policies. So there's no easy answer to whether we should focus on groups or individuals.
That's it. It's a complex issue. How we define these inequalities, it impacts how we see the problem and how we try to fix it.
Okay, so we've talked about the reality of health inequalities, the things that cause them, the debate about how to define them, and the challenges of figuring out what causes what. Now let's dig into the how. How do these social factors actually get under our skin and make us healthier or less healthy?
This is key, and it's tough. We don't have all the answers yet. The exact ways that social factors mess with our biology, it's complicated. But researchers like Johann Mackenbach have identified a few main pathways that seem really important.
Okay, what are those pathways?
The first is the childhood environment. If a family is struggling, it can impact the mother's health during pregnancy, which can affect the baby's growth. You see things like low birth weight, premature births, and then after birth, kids in disadvantaged families, they're more likely to be exposed to bad things, poor nutrition, pollution. All this can have long-term effects on their health.
Makes sense. What's the next pathway?
It's about the material conditions you live in throughout your life. This is pretty straightforward. Low income, it can mean you can't afford healthy food, clean water, safe housing. It can mean you have to work in dangerous jobs or live in neighborhoods with environmental hazards. These things directly impact your health.
Those connections seem pretty clear-cut. What about the third pathway?
This one is about social and psychological factors. These seem to be especially important in richer countries where, even if people aren't necessarily poor, there's still a big health gap between the rich and the poor. And chronic stress, that seems to play a big role in connecting social circumstances to health problems.
Stress, how does that work?
Well, our bodies have this natural response to stress, the fight or flight response. It's actually helpful in short bursts. But when you're stressed all the time, it starts to cause damage. You have these stress hormones like adrenaline and cortisol that are constantly elevated. And over time, that can lead to all sorts of problems. Higher cholesterol, increased risk of blood clots, heart disease, stroke, diabetes, even problems with thinking and memory. It's like wear and tear on your body from being stressed out all the time.
So it's not just about feeling stressed, it's about actual physical damage from prolonged stress.
Exactly. And researchers have connected this stress response to a bunch of different social factors. One is your social rank. They've done studies on primates, and they consistently find that the lower an animal's rank in the group, the higher their stress hormones, and the more likely they are to have signs of heart disease. Even big changes in social rank can trigger a stress response.
It's amazing that your position in the pecking order can actually affect your body like that. What other social factors are linked to this stress pathway?
Low job control is another big one. The Whitehall 2 study, remember that one? They found that people who had less control over their work, they were more likely to get heart disease. And this was even after they took into account other risk factors. So feeling like you have no say in your work, that can be really bad for your heart.
And often people with lower paying jobs, they have less control over their work, right? So it's like a double whammy.
Exactly. And then there's racial discrimination. This is a huge stressor, and it contributes to racial health disparities on top of socioeconomic differences. Experiencing discrimination regularly can really damage your body over time. There are even studies showing that discrimination is linked to changes in the brain, specifically in areas that deal with stress.
That's heavy stuff.
Yes.
It shows that social injustice doesn't just affect you socially and economically. It can actually make you physically sick.
Absolutely. And then there's poverty, especially in early childhood. This can create what they call toxic stress. Kids growing up in poverty, they're often exposed to multiple bad things, like their mom being depressed, abuse or neglect, even violence in their community. This constant stress response during childhood, when the brain is developing, it can have lasting consequences, affecting their health, their education, even their job prospects later in life.
So we're seeing how tightly connected social inequalities are to our biology and our health. But like you said, we're still learning about all of this, and some of these pathways are still being debated.
Right. Some researchers have questioned, for example, the link between job control and health. They say things like a person's health in early life or their parents' socioeconomic background. Those might actually explain some of the link. So maybe job status is more a sign of pre-existing vulnerabilities, not a direct cause of bad health.
And to really make effective policies to reduce health inequalities, it's not enough to just know that things are connected. We need to understand the details of how they're connected, the mechanisms behind it all.
Exactly. Angus Deaton, the economist, he makes this point really well. He says that without understanding the mechanisms, our efforts to fix things might be totally off target.
Okay, so we've laid out the problem.
Yep.
These health inequalities are real, they're deeply connected to social factors, and figuring out those connections is tricky. But now, the big question. What makes these inequalities unjust? What are the philosophical arguments here?
This is where we move from describing the problem to evaluating it morally. In public health, there's this idea of health equity. Health inequities are seen as differences in health that are avoidable, unnecessary, and from a philosophical viewpoint, unfair.
Sounds like a good starting point. But I'm guessing there's some debate about what exactly avoidable and unfair mean in this context.
You got it. There's a lot of discussion about whether avoidable only refers to things caused by social factors, or if it also includes things that might be natural but can be treated or prevented. For instance, some philosophers, the luck egalitarians, they say even natural health inequalities can be unjust if society could have done something about them. They believe in a strong societal responsibility to fix things, even if the cause isn't social. Others say no, health equity should be about fixing injustices that come from society.
And it's that unfairness part of health equity that brings us to justice. If we're going to use health equity as our goal, we need to know what a just distribution of health actually looks like.
Exactly. And philosophers have come up with different ways to answer that question. We can group them into two categories: freestanding approaches and derivative approaches.
Can you unpack those for us?
In a freestanding approach, the injustice of the inequality is front and center. The inequality itself is seen as wrong, even if we don't know exactly why it happened. The focus is on the outcome, the inequality, and then figuring out the causes. A derivative approach, though, says the injustice comes from the causes of the inequality. So if a health difference is caused by something we already knew is unjust, like discrimination or unfair policies, then the health difference is unjust too because of its origins.
So freestanding is like, this gap is wrong, period, and derivative is like, this gap is wrong because of how it came about. Let's look at some of those freestanding approaches first.
One simple one is just applying the idea of equality to health. So you get equality of health, where any health difference that could have been avoided is seen as unjust and should be eliminated.
But the luck egalitarians, they'd push back on that, right?
Absolutely. They'd say, hold on, not all inequalities are the same. They distinguish between brute luck, which is stuff you have no control over, and option luck, which comes from your choices. Only inequalities from brute luck are unjust. So if someone's bad health is because of choices they made, that's not necessarily unjust.
And both of those views, the strict equality view and the straight-up luck egalitarian view, they both run into what's called the leveling down objection, right?
Exactly. That objection says, if all you care about is equality, then it doesn't matter if you improve the health of the worse off, you could just make the healthier people less healthy to even things out. That doesn't seem very ethical, does it? If someone has cancer, it's not okay to harm a healthy person to achieve some kind of statistical equality. Or think about the problem of deaths of despair. That might reduce some life expectancy gaps, but it's obviously not a good thing.
So some luck egalitarians have tried to fix this problem by acknowledging other values besides fairness. And then there's Shlomi Segal, who came up with this luck prioritarian view. How is that different?
Seagal's idea is you prioritize the health of those who are worse off, but with a twist. You first look at how much effort people put into taking care of their health. So, you prioritize those who tried hard but are still worse off because of bad luck. Then, among those who put in the same effort, you prioritize the ones who are the sickest. It's about giving everyone a fair shot at good health, not just about making everyone equally healthy.
And there are also those approaches that focus on social relationships, right?
Right.
The social or relational egalitarian views.
Yes, those say that health inequalities are unjust if they prevent people from interacting as equals. So, if someone's health makes them vulnerable to being dominated or excluded, that's a problem. Even if their health issues came from choices they made, it's still unjust if it damages their social standing. But these views have to grapple with the question of how much inequality is too much? When does it actually start to undermine equal relationships?
And finally, for the freestanding approaches, there are the sufficientarian views.
These are all about making sure everyone has enough health to live a good life. It's not about eliminating all differences, it's about making sure everyone meets a certain minimum standard. So you have folks like Powers and Faden who focus on ensuring a good level of well-being in several areas of life, including health. And Jennifer Prauruger, she talks about a minimum threshold of health capabilities. The main goal here is to close the gap between those who have enough and those who don't.
Right. But even if these views avoid the leveling down problem, they have other issues, right? Like, should we just ignore inequalities that are above that minimum threshold? And how do you decide who to help first among those who are below it? Plus, some people say that these freestanding approaches focus too much on health and not enough on other important things.
That's a common criticism. Hausman, for example, he says we shouldn't get hung up on health differences if they don't actually reflect differences in overall well-being. And Weinstock, he worries about what he calls health consequentialism, where every policy decision is made just to achieve a certain distribution of health, even if it means ignoring other important values. Powers and Faden, they try to deal with this by looking at well-being in multiple areas, not just health. But that raises a new problem. What happens when different aspects of well-being clash?
So lots of different ways to think about why health inequalities might be unjust, and each view has its own strengths and weaknesses. Now let's move on to the second category, derivative approaches. What's their take on health injustice?
Derivative approaches say the injustice comes from the roots of the inequality, from the things that caused it. Norman Daniels is a big name here. He argues that John Rawls' famous principles of justice, the ones about fairness, those can be applied to health too.
How does he connect Rawls to health inequalities?
Well, Rawls has this difference principle that says inequalities in wealth are only okay if they benefit the least well-off. Daniel says this applies directly to income and jobs, both big factors in health. Then there's Rawls' principle of fair equality of opportunity. That means everyone should have a fair shot at things like education, including early childhood programs. Daniel says this is key for tackling educational inequalities, another big health determinant. And of course, there's Rawls' principle about basic liberties, like the right to participate in politics. That's relevant too because it affects people's ability to speak up for their health needs. And finally, Daniels, based on his own earlier work, says that fair equality of opportunity also means everyone should have access to good health care.
So Daniels is saying that if we follow Rawls' principles and create a just society, the health gap will shrink naturally, because those principles target the root causes of health inequality.
Exactly. He really believes that social justice in general is good for population health and its fair distribution. He thinks that any health differences that remain after we achieve social justice, those are probably unavoidable and therefore okay.
But Daniels' use of Rawls, that's been challenged too, right?
Oh, yeah. Some philosophers, like Anand and Peter, they point out that Daniels can be a bit fuzzy about how he applies Rawls' principle of fair equality of opportunity. Sometimes he uses it to talk about social factors like income and education, and sometimes he uses it to talk directly about healthcare. So it's not always clear whether any leftover health inequalities, even after fixing the social problems, would still need to be addressed under this principle.
And others have tried to reimagine or expand on Rawls to deal with health inequalities more directly. I'm thinking of folks like Fishman and McKay and Tees.
Right. They argue that we need to think about the social basis of health as something fundamental, like a basic good in Rawls' theory. Fishman and McKay even go a step further. They want to add a whole new principle of justice that focuses on improving the health of the most disadvantaged. They say good health is necessary for people to develop their moral capacities. Nees, he thinks the social basis of health should be governed by Rawls' difference principle, the one about inequalities only being okay if they benefit the worst off. But he admits it's tricky to figure out how to weigh health against other goods, like wealth. He thinks democratic processes should decide those trade-offs. Interestingly, neither Fishman and McKay nor Nees really talk much about what to do about health differences that might still exist even after we apply their principles. Maybe we need both freestanding and derivative approaches to really get a handle on this.
This really shows how many different ways there are to think about whether health inequalities are unfair. It's not a simple question.
Definitely not. And one thing that comes up in a lot of these discussions is the idea of individual responsibility. What about the choices people make that affect their health?
Right, things like smoking, what you eat, whether you exercise, those are huge factors in how healthy people are. But as we've discussed, the link to social determinants can be messy.
For sure. We know that unhealthy behaviors are more common in lower socioeconomic groups, but whether those choices are truly free, whether they're made without being influenced by social circumstances, that's a big debate. Some studies suggest these behaviors might explain a lot of the health gap in richer countries, but others have found different results. It seems like the link between behavior and social context can vary a lot depending on where you are and what culture you're in.
And this brings us back to those luck egalitarians and the whole responsibility question. If people's choices are contributing to health inequalities, are those inequalities still unjust?
Generally, luck egalitarians say no, if it's a result of a choice, it's not unjust. They believe we should compensate people for bad health that comes from bad luck, but not for bad health that comes from their own choices. This raises some tough questions about healthcare, like, should someone who got lung cancer from smoking be treated the same as someone who got it without smoking?
That brings up the abandonment of negligent victims objection. Is it really okay to deny someone health care because of their lifestyle choices?
A lot of people find that idea very troubling. Some luck egalitarians have tried to address this by saying that even choices can sometimes lead to unjust outcomes, and a just society would still take care of people who make unhealthy choices. Others argue that it's not always fair to blame individuals for their behavior, especially when those behaviors are shaped by social conditions and a lack of good options.
And then there's Rawls, with his idea of a social division of responsibility. He says that people can only really be held responsible for their choices, including health choices, if society is just to begin with. If the basic structures of society are unfair, then people's choices, even if they seem free, might not be completely free after all.
Davies and Savulescu, they have a different angle on this. They say that in healthcare systems based on solidarity, we have a duty to each other to take care of our health. We shouldn't burden the system with costs from refusing golden opportunities to be healthy, assuming we're in a situation where we can actually make those choices responsibly. But they emphasize that this individual responsibility only makes sense if society as a whole is set up to support those good choices and if there's real solidarity in the system.
So even though the idea of taking responsibility for your health sounds straightforward, the philosophy behind it is way more complicated. There are a lot of things to consider. What other big challenges are there to this idea of individual responsibility in health?
Well, Daniel Wickler, he's very critical of this idea, especially the straight up luck egalitarian view. He brings up the abandonment of negligent victims problem, but he also says it's practically impossible to always know what choices were truly voluntary. Plus, he thinks we tend to judge some health choices as bad, but overlook others. He says personal responsibility should be a goal, something we encourage, but not a hard and fast rule for deciding who gets health care or whether a health outcome is just or unjust. Norman Levy also argues against putting too much emphasis on individual responsibility, especially for people in lower socioeconomic groups. He points to things like reduced ability to make good choices, lack of education, and stressful environments. He believes that society often bears more responsibility for those health outcomes than the individuals themselves.
But of course, there are people who disagree with that. Some say that just because society influences your choices doesn't mean you have no responsibility at all. Others say it's patronizing and disrespectful to assume that people in lower socioeconomic groups can't make rational choices. And there's a broader concern that if we focus too much on individual responsibility, we might ignore the bigger social problems that are driving these inequalities, and we might end up stigmatizing people for behaviors that are often shaped by forces beyond their control.
So, yeah, this whole question of responsibility in health, it's a very live debate. There's no easy answer.
Okay, last but not least, let's talk about global health inequalities. We said at the beginning that the differences between countries are often even bigger than the differences within countries.